creating safety and trust, and we'll go over the objectives. So the objectives for this module in particular are to identify key differences of emoting, the adaptive art of articulating emotion, experiencing emotions, and the roles in therapy as a client with C-PTSD. What is it like for the client? We often talk about what it's like for the therapist and what to do, and we will go further into that in later modules as well. We're going to understand internalized oppression, discuss and go over internalized stigma, shame, and grief. We're going to discuss how to cultivate true internal and external safety and trust, how to really create that, and what to look for, things that we can do experientially, and things that we can do on an emotional level to help create that external safety and trust, as well as internal for that client. We're going to recognize and assist with body entrapment. That's what I call it, and we'll go into that further. And understand and identify methods of experiential somatization and that somatic release. First, let's talk about the art of emotional expression and the art of emoting. Everyone has feelings. We know this. Some have taught themselves to be less attuned, to numb out, or to be avoidant of those emotions and self-protections. And it is really important to look at feelings, emotions, numbing, avoidance, and those behaviors as self-protection and as survival mechanisms. Some may express emotions frequently. So while some may not express emotion or have what we would see particularly as an under-expression of emotion, we may also see the opposite of what may seem like an over-expression or maybe an intense expression of those emotions. When someone has taught themselves to numb experiences or to dissociate, the coming on of emotional experiences can be very, very intense. The way I look at it is like someone with chronic pain. If someone has learned to avoid pain throughout their lifespan, and then suddenly are no longer using those survival mechanisms to numb them or to avoid them, when that pain in the body comes back, it is extremely intense. And so that's something just to think about. Is to the external world, it may seem like an overabundance of emotion or an underabundance of emotion, but really these are the survival mechanisms and the protections that people have created for themselves to keep them safe, whether it be emotional safety or physical safety, whatever it may be, some form of safety and survival. So feelings may seem like a luxury or a privilege that someone experiencing C-PTSD may not have had. I like to use the word a privilege. It is an interesting word to use with the words emotions or feelings, because often when people in complex trauma situations have learned to numb or have had to numb, then feelings like helplessness, hopelessness, powerlessness, or those other extreme saddening or grief sort of emotions seem to be self-reflective, and one has to be really attuned to the self. And so in order to sit with those emotions, it is a privilege of safety to be able to do so, whether that be with a person or in an environment. And so I like to look at feelings and emotions sometimes as luxuries or as privileges. When one is in survival continuously and living in environments or near people that are unsafe or perceived to be unsafe, a client may feel like taking the time to be with oneself, their feelings and their emotions could put them at risk for harm or be really threatening. So while it is something that our clients want to do and they want to work through and process, it is a practice. It's like meditation. One has to learn how to emote. One has to relearn how to sit with hard emotions without allowing it to flood or to overwhelm the body and to overwhelm the consciousness. Emoting is the biopsychophysiological response to experiences that affect us. The outward expression of emotional responses we are experiencing as we're experiencing them. So emoting is, let's say you're sad, and you begin to cry. Externally, looking at that person, we may be able to assume, oh, this person's really sad, or this person's grieving, or this person's feeling dysregulated. So, emoting is that outward expression of the feeling that they're feeling internally. Emotional dysregulation is an intense emotional response and experience, often prolonged and frequent. Dysregulation can be somatic and physiological. When I work with supervisees, often there's a misconception that emotional dysregulation is up and down in mood. And that can be true, yes. But most emotional dysregulation that we see with complex trauma is really an internal experience. It's that internal war zone of what I know versus that felt sense. And so that's the dysregulation, and that disconnection of alignment too between thought, emotion, and feeling. And so emotional dysregulation can look very different. It can look like numbing. It can look like someone is not having an outward emotion or that emoting experience. One may not be able to decipher what a client is feeling unless we ask. And so it's really important that we do those check-ins and we start talking to them about what is going on in their body, their mind, their hearts, their souls. And that way we can also see how those defense mechanisms and those survival mechanisms are protecting the client. I created a list of intense emotions, and there are some that are repetitive on here, and I have reasons for that. Often, when my clients see something in repetition, they're more likely to say, yep, that is what I'm feeling. I just really didn't want to say it out loud. And then there's some that automatically come up and come out. And so there are some that are repetitive in here, and that's okay. So some of the ones, of course, are shame. And we'll talk a lot about shame here in a minute. Disconnection or feeling disconnected, feeling numb or not feeling anything at all, wanting to feel. Often, when my clients are numbing or feel dissociative, they want to feel. They don't want to feel as intensely, but they want to feel something. And so that's when we may see things like self injury, self punishment, and ways that the client is trying to work toward feeling something. Empty, so that feeling of I'm not a person anymore. I'm just empty. I'm a shell of a person walking around, and I don't know what to do with that. Misunderstood. My clients often have feelings of feeling misunderstood, or no one will understand them. They don't fit in anywhere. You may hear some of this dialogue. Conflicted or conflict. So they're kind of still in that war zone within themselves, that battle. Overwhelm. This can be physiological, this can be cognitive or emotional. So again, it's that coming back to the self and being attuned with oneself and knowing when that overwhelm is happening. Maybe feeling inadequate, oppressed, guarded. Many clients come in, I hear the word resistant a lot. I use guarded or protective of the self. So someone may be guarded in that they may be reluctant to share or reluctant to come in and trust that this process is really for their benefit and there's no other side dialogue going on about them in the therapist's head or the therapist's heart. And there's that constant worry. And so they guard themselves from truly opening up and from truly offering oneself to themselves and to the therapist. Another emotion may be anxiety or self-consciousness, intense fear, guilt, feeling alarmed. This again can be physiological, emotional, psychological, cognitive, that the internal alarm bells can go off and the body may be responding. The thought alarm may be going off as well, thinking thoughts about abandonment or rejection, but usually it is about what may happen to them, what may happen emotionally, will they be able to come back from it, and will they feel flooded, and how to deal with that. So that alarm feeling. Desperate, distressed, uncertainty, feeling stigmatized, embarrassment, feeling worthless, hopeless, helpless, deep anguish, feeling lonely, sadness, heartbreak or heartbroken, agony, feeling indecisive. That could be about oneself. That could be about a decision that they're making in their life. That could be about whether or not they want to share something or whether or not they trust this process, feeling indecisive, maybe passive, exposed, exploited. They may feel tormented, whether it be by their present or their past or themselves. Again, I have agony, despair, more overwhelm, apprehensive, devalued, confused, humiliation, betrayed or betrayal, a sense of gratitude, a sense of compassion, loyalty, loving, appreciative, considerate, amused, creative, and empathetic. These are just some intense emotions that clients may or may not have. I like to go into more intense sections of emotional response as well as emotional verbiage because words are powerful. And sometimes when we offer these words to our clients, or if they feel stuck and they can't find the word for themselves, this can help them feel understood, validated, and like they can share. Notice a majority of the categorized happy or caring emotions are typically expressed and felt intensely toward others. So when we talk about things like gratitude, compassion, loyalty, loving, appreciative, considerate, amused, creative, empathic, those are all emotions that one may have for themselves, but people with complex trauma or C-PTSD tend to really struggle with that feeling of those feelings for themselves. And so it's not really directed internally. Instead, they may be external direction of emotion or emoting. And of course, one of our goals may be with the client to start to feel those things for themselves as well. Personal identifiers of emotions. So triggers that can be unpredictable because of their multitude and lack of attunement cultivated for protection. This triggers alone, we talk about triggers a lot. And the client with complex trauma, it is complex. So there's a lot going on internally. There's a lot going on externally, even in their present day. When we're working on the past or we're working on how the past is showing up in the present, triggers are of a multitude. It is very difficult for someone with complex trauma to pinpoint sometimes what triggers an emotion, what triggers them cognitively to have negative self-talk, what triggers them to feel reluctant or overwhelmed because of the vast experiences of possible attachment disruption or continued traumatic experiences. They are all webbed together. And so when traumatic experiences are wed together and these feelings seem familiar, for example, someone feeling overwhelmed, let's go with that one, it's an easy one. If someone's overwhelmed, let's say they come in and they've had a really hard work week and they are overwhelmed. That feeling may then be interconnected to other traumatic experiences. And so it's hard for them to decide which one was the trigger. Was it an argument that I got into with a friend? Was it my workload? Was it all of these things that can be really, really complex and really difficult to pinpoint for them? Another personal identifier of what may bring on extreme emotion is avoidance of that emotion. Avoidance of emotion, thoughts, body sensations, places, people, reminders, that actually intensifies a person's emotional response in the long term. So while avoidance and numbing can be really helpful and it is a survival mechanism, it can also prolong that intense emotional experience. And that's why when we talk about sitting in discomfort or sitting with yourself or sitting in those emotions, you know, really easy for us to discuss that. And it's easy for us to tell our clients about sitting in their discomfort. But what does that actually mean? And what does that look like? And if we're avoiding those things, what does that mean? And what does that look like? So it's really important that we can articulate with our clients what their avoidance may look like and how it's impacting them in the now and how it impacts them in a long-term sense. Another personal identifier of emotional extreme responses could be self-hatred. With complex trauma and complex post-traumatic stress disorder, self-hatred is huge. There's this extreme attunement to the self and this need to attribute that anything going wrong is because of themselves. Something they did, something they said, maybe I looked at them wrong, did I not articulate correctly? This rumination starts to happen, which creates this overwhelm and this flooding of multiple fears and multiple emotions that are really difficult to decipher and difficult to work through. So that self-hatred comes up in many ways. And this can be an internal experience, and this can also be a physical experience. The next one is self-judgment. Self-hatred and self-judgment can go along with each other. Typically, one hates themselves when they're judging themselves or judging a thought or judging a feeling that they're having. Like, I shouldn't be having this. This is where we go into those thought distortions, like this shoulda, coulda, wouldas. I should be over this by now. I should be able to, regulate myself and get through this. This is something people do every day. And why is this so hard for me? And so those self-judgments come in, and then it trickles down to self-hatred. We also have self-blame. It's my fault. I should have done something different. I could have prevented this. And those thoughts and create these intense emotions as well. Pete Walker talks about the inner critic and how the inner critic plays a huge role in that shame and that guilt presence, which can be really, really intense emotions. That shame alone can overwhelm the body. It can overwhelm the thought process. It can overwhelm just the soul and make someone feel empty and worthless and helpless and powerless over their own selves. Hypervigilant behaviors, thoughts, and feelings. Again, that goes back to also reconnecting into this inner critic, the self-blame, the self-judgment, the self-hatred, and these triggers. Being hypervigilant is often a protective mechanism. There's a lot of shame often surrounding these hypervigilant behaviors, these hypervigilant thoughts, that rumination of what I did wrong in a social setting. I don't know for most people if you've ever experienced, going to a social event and then that night just laying there thinking about all the things you could have said differently, or what did you say wrong, or do I remember what I even said? Did I come across well? I wonder if people like me. I wonder if I even like myself. And so those hypervigilant behaviors, thoughts, and feelings can come in and really flood the self. More hypervigilant behaviors could be loud noises and just making sure that their environment is safe, going into a therapeutic office and having mapped out the whole entire office just in case, something were to happen. And that way they know how to protect someone else. And they also know how to protect themselves. There's this loyalty to hypervigilance. The next one is visual flashbacks or intrusive images. There are multiple types of flashbacks. For complex trauma in particular, we will go into in another portion of this in module 3, the different types of flashbacks, what to look for and what they mean and how they may feel to the client. But visual flashbacks or intrusive images can be really frustrating for a client because they interrupt. One of my therapists said, they're rude. Like, flashbacks are rude. They're intrusive. They interrupt what you're doing, what you're saying, how you're saying it, and how you're feeling about yourself in that moment. So most common with PTSD or C-PTSD is emotional and somatic flashbacks. And so that's what I'm talking about in that body, and feelings that are familiar, again, connected to these webs. So it's really difficult to decipher where that feeling is coming from and why we're having it. Sometimes working with clients, it's really important that they understand it's okay to not know the why and sitting with that self-compassion, which again is a really difficult topic. And we'll go into how to help our clients get to self-compassion and self-attunement as well. But those somatic flashbacks and those emotional flashbacks are so familiar. And they usually come from multiple situations and multiple traumas throughout the lifespan. The next one is internal conflict of what is known versus what is felt. So again, it's that non-alignment of, well, I know this, I know that my flashbacks are just flashbacks and I'm not in that moment, but it feels like I'm in that moment. I'm reliving that moment. So that internal conflict of what is known versus what is felt. I know I can do meditation and I know that these things can work and help physiologically decrease this extreme emotional response, but I am feeling overwhelmed. I am feeling flooded. I am feeling like I am in danger. The next one is difficulty separating thought versus feeling. Sometimes they feel really enmeshed. Like, I know for myself, I tend to feel stuff in my body first. Often thoughts create emotions and trigger that hypervigilance in the self, but the thought isn't what comes up first. It's typically with C-PTSD in the body. It's this alarm and then thoughts about the alarm. The next one is relational discourse. So any time in someone's relationship, if you have complex trauma or C-PTSD, we know that C-PTSD often is created by attachment disruption. It's also this ongoing relationship trauma because we have been traumatized by a person. And so if we are people and we're a therapist, we're a person. And so that in and of itself, that therapeutic relationship can be just as triggering emotionally, physiologically, and spiritually as, let's say, talking about a trauma or bringing up a traumatic event. If one is in a relationship with their partner and their partner is heightened in their emotional response, taking responsibility for those emotions and trying to control the room per se, and that constant look for microaggressions or that constant hypervigilance of what's going on in the room and how to create a calm sense of being can be a relational discourse. Environmental and cultural factors. So these all play a role in the intensifiers of emotion. And we'll talk a lot about culture. Learned responses to intensified emotions. There are a lot of them. I am only going to go through some of them very briefly with you. So this is a short list of them. I put a lot of stuff in these slides because there's a lot of information to go through in each module, but I do have to condense it in some way. So some of the learned responses to emotions may include, but are not limited to, emotional restriction or numbing, internalized or externalized frustration or anger, distancing. Distancing can be due to fears, feelings, feeling alone, misunderstood, distrust in the world. Again, we're going to go back to those intensified emotions. And, you know, here's a key aspect when we talked about in module 1, the differences between things like singular PTSD, borderline personality disorder, and complex post-traumatic stress disorder. That's one of the things we're looking at is it's not necessarily a fear of abandonment like it would be with BPD. It's this fear of being hurt or harmed or continuously re-experiencing what has already been experienced. That's the timeline in the history that someone may have, and therefore that's real data. That's real data to them. And so they would distance instead of pulling closer and wanting them closer. It would be like I'm just going to go ahead and protect myself and save myself from all of this. And I may either emotionally distance, physically distance, or even cognitively distance myself from someone or something. Another learned response is suicidality. I always talk to my clients, and we'll go into in depth how to respond to suicidality or suicidal ideation. This is not the problem. This is a perceived solution to a much deeper problem. Okay, and so suicidality can be a learned response. Somatic and physiological responses can also be a learned response. we know that when we create neural pathways in the brain, we may utilize those pathways. So for example, if someone is in a threatening situation or a perceived threat, let's say they go to the movies. I'm using very simplistic forms here, but this does happen, is someone goes to the movies and something traumatic had happened at a movie theater. Somatically and physiologically, their body has learned to respond to threat. The movie theater is a threat. This is threatening their safety. This is threatening their body or someone else's safety. And so protecting the self, but also protecting other people may be intensifying those emotions in that process. Self-punishment practices or self-harm. So I put self-punishment, not just self-harm, because there are multiple ways to harm the self. Some of the ways that we talk about a lot are the physical harm or the physiological harm that one may do to themselves. And that could be cutting, burning, bruising, pinching, scratching, trichotillomania, pulling out the hair, picking. But it isn't always things that are physically obvious. It could be things like overworking, being overproductive, wearing oneself out, overexercise, overeating, restricting eating. There are many ways to self-punish. The next one is hypervigilance. So that is that learned response can intensify emotions as well, that nervousness or that anxiety. Most of my clients with C-PTSD don't view hypervigilance as anxiety. They view hypervigilance as hypervigilant or protective. No, I'm just hyper aware of my surroundings. I am just extremely aware of when I walk in a room, I take note of everybody in the room, what they're wearing and their behavior. And I stand guard for that. So that could be hypervigilance, opposed to someone without C-PTSD may say that they're anxious or they're socially anxious. And then apologizing or over apologizing. So this too is a learned response to those intensified emotions. How can I make this better? How can I also control the narrative about myself so that people know that I'm kind and continue to say, I'm sorry, I'm sorry, I'm sorry. Again, that goes back to also taking responsibility for things that may be out of the person's control and taking responsibility for other people's emotions, thoughts, actions, and just over responsibility in general is that continuous, I'm sorry, I'm sorry, I'm sorry. And so in therapy a lot, I hear therapists say like, you don't need to apologize, it's okay. Or even ask, I hear that you apologize a lot. Can you tell me more about that? And it's really important to go into the reasons for apologies or how that's protective for the client. All right, some more learned responses would be people pleasing. So this is that kind of fawn response, unconsciously controlling the narrative and avoiding conflict or discourse. Conflict and discourse in general can be huge, huge, huge triggers for intense emotional and somatic experiences for someone. And so it's really important to look at people pleasing, not necessarily as a bad thing. It can be very protective, but then how is the person abandoning themselves by doing this? And so that could be a great conversation. We have a tense attunement or a lack of attunement to one's body, thoughts, or emotions. So the lack of attunement would typically come with dissociation, or it may come with that numbing experience. In my experience, dissociation in particular isn't about a lack of attunement. It's a hyper attunement to the self, which then overwhelms the body and overwhelms the mind and overwhelms the emotional state in the nervous system, creating this distancing for the self. So it's an over attunement that turns into what may feel like a lack of attunement. And then we have the intense attunement, and we went over that too in module 1. This is the difference between singular PTSD, complex trauma, and BPD as well, is that intense knowledge of what's going on with oneself and what's going on within the body. They may lack affect to a situation or have extreme affect that may not fit the realism of the situation to someone without complex trauma. We've talked about that a little bit, those highs and lows that come. Um, it may feel really intense to the person, and that's their truth. It may feel so intense that there's a numbing effect. Persistent sadness, helplessness, or hopelessness, these are learned responses as well. Many have heard of, people using the terminology learned helplessness, that need for constant assistance or attachment or other things within their relationships, even with work. There could be a huge denial of helpless or hopelessness. We'll go into this a little further and more in detail, but a lot of the time when we're working with someone with C-PTSD, we'll see a disowning of parts or a disowning of the vulnerable part of the self. And so there's that denial, like, I was never helpless or hopeless. I couldn't be. That's one of those privileges, is if I sit in helplessness or hopelessness, I can't get through the day. And so that could be the denial of that they were once helpless or hopeless or currently are. Then we have a learned response of dissociation. We will go into that in detail in another module. Distrust and personal silencing. So the distrust of the self, learning that kind of self-gaslighting occurs with C-PTSD. And that, here, I'll give an example. So an example may be a client's coming into therapy and is working with the therapist, and they're like, man, I really trust this therapist. I really want to open up and divulge information to them. I really want to tell my story, or I really want to sit with these parts, and then start to do those things. But then they sit back and thoughts cross their mind of, can I really trust myself though? Can I really do that? Because I've been hurt by so many people, or I've been hurt over and over and over and over again. Maybe I'm misreading the room. Or maybe I'm overreading the room, or maybe I'm underreading the room, And so it's really important that we talk about distrust and that personal silencing. So the person may then choose not to speak at all, or choose to stay silent and not be able to find their voice in that room. Difficulty setting and asserting boundaries. So there's a difference between boundaries and requests. I do a lot of boundary work with my clients, in that setting boundaries is a way for people to really get to know you. It's also a way for you to really get to know yourself. And so asserting and setting those boundaries are a learned response. And typically when someone has complex trauma or C-PTSD, they've learned not to have wants or needs. They're wantless and needless. And so with that comes a lack of boundaries, or not knowing when their boundaries are being crossed, or if they are being crossed, being okay with that per se, even though they're really not. All right, let's talk about the role of internalized oppression, stigma, and shame. I love this quote, and so I added it from the University of Kansas Cultural Competence of 2022. It says, oppression is discrimination carried to its extreme. Oppressed people are not only discriminated against, but are also subject to physical and psychological brutality. I think that's really, really important when we talk about internalized stigma, internalized oppression, and the stigma within our own profession. So internalized oppression are the self-defeating beliefs and meanings that are typically cultivated by our environment, family culture, or cultural contexts. The scripts and stereotypes used for oppressive and discriminatory leveraging or exploitation are turned inward and believed as true. Now, I really resonate with my last sentence here, is the scripts and stereotypes used for these oppressions and this discrimination are leveraged or exploited, turned inward, and believed as true. So often when someone is experiencing external oppression or external discrimination, eventually that wears on the person's internalization of self, of the thoughts about the self, the worldview, and how they integrate into the world. And so it may start as this external experience, but Complex trauma is the ongoing experience of that trauma, and that ongoing oppression and that ongoing discrimination takes a toll on how one feels about the self. And so it turns inward and often can begin internalizing and oppressing the self. So stigma is a marker of shame or discredit, and that's by Merriam-Webster Dictionary. So mental health stigma, I like to talk about a lot, is a huge issue, even in the helping professions. I don't think it's talked about enough, but pathologizing protective behaviors, misdiagnosis, misuse of language and terminology, how professionals and the public speak about people they're treating, they all increase stigma. So I take it upon myself a lot whenever I'm working with supervisees, or if I'm working on a treatment team, or if I'm doing consultation work with businesses. I talk a lot about this stigma. And I talk a lot about how we're talking about our clients. Let's say I have a client who has C-PTSD and they have a lot of emotional dysregulation. They might feel like they don't want to live anymore. And it's been difficult to assist in guiding them to a regulated state. If I were to explain to my client ethically that I think we've worked really well together and I think we've gone as far as we can go, and then say, you know, I actually have a colleague that I think could really work with you well on addressing these next two goals, or are more equipped for that. The way we prep that next therapist is essential. So I've heard in many treatment team meetings, therapists come in and say, okay, so you're going to take on this client. Let me tell you about this client. And they go on and on and on with this pathological language, and also really opinion, non-clinical opinion, that then creates a within. And so it's really important that we're not recreating these stigmas for our clients. A really simplified example is how you hear people in general in the civilian life say things like, oh my gosh, they're so bipolar. Now, what they're really trying to say is that they're moody. They woke up grumpy today and usually they're happy. The way that the language is used stigmatizes those who are actually diagnosed with bipolar disorder. So then there's this skewed view of what it actually is. C-PTSD in that way is very similar. I think borderline personality disorder is often stigmatized as well. Most diagnoses are, to be honest. And so it's really important that we're working within our own profession, not to stigmatize, even with each other. Can you imagine if you're working with a colleague who may have C-PTSD or may have been diagnosed with bipolar disorder, and then here you are talking about a client in that way to them, they're not going to feel safe either disclosing that they may be struggling with this, with a similar diagnosis, right? So we need to be really careful about the stigmas that we project into our own profession and onto each other as well. All right, shame. Okay, so here is a quote from Brené Brown. A lot of people love Brené Brown. She says, I define shame as the intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. Something we've experienced, done, or failed to do makes us unworthy of connection. So a lot of shame is built around this disconnection and this disconnection from others. And so when we talk about shame, it can be internalized shame. It can be the disconnection from the self. It can also be the disconnection from others, or feeling like someone doesn't fit in, or they'll never be accepted if somebody sees all of themselves, or sharing all of themselves will put them at risk for not being liked, loved, accepted, or have that sense of belonging. So then there's toxic shame. And I like to use the word toxic shame because it is highly developed in people with C-PTSD. And this includes, but is not limited to, culture, environment, stigma, internalized oppression, discrimination, childhood adverse experiences as described in the ACEs assessment that we talk about in module 2, abandonment, abuse, neglect, bullying, overly high standards, perfectionism, exclusion, unwanted exposure, trauma, re-traumatization by the system or authority figures, poor therapeutic experiences or interventions, external and internal scripts, secrecy, silence, and more. This is that ongoing shame response that continues throughout the lifespan. So all of these things are working against the person per se, in that I'm a bad person, not that I did something bad necessarily, that does come into play as well, but I'm a bad person. And because these traumas occurred, or because these traumatic experiences happened, or because of the way that I'm responding to these experiences, can create and cultivate that extreme toxic shame that is really difficult to work with within the self as an internalized experience and really work through. There's a lot of grief that plays a role in that, and we'll talk about grief too. So some of the common shame scripts that you may hear is, I'm a bad person, I'm defective, I'm crazy, I was born to be used by others, I'm undeserving, I'm unlovable, I'm disgusting, I'm unworthy, I caused this, I could have prevented this, and if I weren't, fill in the blank. That self-blame, that self-hatred, that self-critic, really typically exacerbated by the external experience, whether that be maybe someone tried to come forward and explain their experience and then was re-traumatized by the system. Or maybe this person was a child and had to internalize this experience and abandon the self to remain safe, to make sure that they're meeting the needs of others so that they can save themselves or what little they feel like they have of themselves left. Okay. So more about shame. The term I use is characterological shame. It's a big word. And it is comparable to what you'll see in the literature as characterological self-blame. So this is a strongly held, usually underlying belief that the person's mere experience or their mere existence were the direct causes of the traumas and the trauma response. Something inherent or something they may feel is deeply defective about them that caused the traumatic experiences or responses. I tend to work with my clients in a way, there's a lot of research and bulk of knowledge and information out there about how when one has experienced complex trauma, and this is some of the wording that's out there, is that the person then chooses to be in relationships that re-traumatize or that reflect their own feelings of worthlessness and devalue themselves. I like to shift that language because that sounds very blaming, especially with someone with PTSD who already is taking responsibility for the abuse that's already occurred. And so instead, I like to look at the relationship dynamics and how that person is seeing themselves in the relationship, not necessarily seeking out abusive relationships, but how are you seeing yourself and how is that interplaying with the relationships that are being cultivated, right? So there's taking away and validating that you know, if we have this language that I often see in the research, it's as, so here I was as a child continuously traumatized, and now I'm choosing to be re-traumatized. And so everything that's happening is really my fault. I was born literally to be traumatized and to continue these traumatic experiences and trauma responses. So really decreasing that characterological shame around that is really important, and talking about it from a different framework. We also have behavioral shame, which is comparable to behavioral self-blame. in the research. So these are feelings of being deserving of the traumatic event because of something the person believes they could have done differently, or something they didn't do that they now believe, had they done so, the experience or responses could have been avoided. We see this a lot in singular PTSD, is this behavioral shame. In complex post-trauma, you will see it too. You'll see both as well in singular PTSD. But both of these are huge tenets and experiences of that with someone who has C-PTSD. That behavioral, I could have done this differently, I could have, and really breaking down each traumatic experience and their role in it, as well as that characterological shame of, you know, this is just how I was when I was born, for other people to use me or to abuse me, right? Okay, so let's talk a little bit about grief. Grief is a compounding experience. Most of my clients that come in with C-PTSD, when I ask what they're feeling, or I say, you know, what's going on in your body? What is the emotion? Can you give me a word? They look through my list. They may not offer me grief. They may not say grief. A lot of times with my clients, I might have to say for myself to them, it sounds like you're grieving. It sounds like there's a loss here. And I think commonly when I work with people who have C-PTSD, they think of grief as the loss of a person or loss of a connection of a person. Very little do they think about the loss of connection to the self, which can be a huge portion of working through the grieving process. So compounding grief is often not a word utilized with someone with C-PTSD, but by offering this as a feeling, the connection of grief can assist in that deeper work. There are many reasons for intense griefs that will show up. And here's just a few that I go over with my clients when I see it, is that loss of time, loss of childhood, loss of self, loss of relationships, loss of access to resources, loss of agency or discernment, loss of trust, loss of safety, loss of community, ambiguous grief that can be indescribable, grief that can be repetitive, and loss of memory. Grief is something that is deeply held and terrifying. I'm a firm believer in the fact that as a therapist, I'm constantly doing grief work. Grief work is something I'm doing daily. It may not be what happened to you, but what didn't happen to you, or what you didn't receive that you needed, or validation, or a response that you needed. There's so many ways that grief show up in our everyday life, and it is a blank experience. Everyone has different experiences with grief. And so it's really important to take a moment, just take a second and think about grief in your life today, in the present. Have you felt a loss of time today? Have you felt a loss of yourself? Have you abandoned yourself today in some way? Have you needed validation today or a break and felt like you couldn't give that to yourself, or the people around you wouldn't respect it if you did? That's all grief. That's all loss. Though we don't always take a moment to sit with that, and we don't always acknowledge it as what it is, those are grief experiences. So that's really important. Okay, so now we're going to move to cultivating external safety and trust. What does this look like, and how do we actually do it? We talk about creating safety. We talk about creating trust with our clients. We talk a lot about rapport building, and that's all very, 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 very important to this process. I wanted to dive in and give a deeper look into what that actually is and how we can promote it. So one of the things that I put is pace yourself and assist in pacing your client. So this is that gas brake system. And we talk about that. We'll talk about that throughout the modules a little bit here and there. So as the therapist, creating external safety is modeling and mirroring that pacing. Following your client is really important. I have sat with new therapists working with trauma who hit the brake system a little bit too quickly because they are uncomfortable or they're not sure if they can help assist stabilizing a client if the client gets flooded or overwhelmed. It is important to know yourself in this process, and it is important to know when you're feeling overwhelmed as well without stopping your client from their comfort zone and their comfort level. Remember that this process is about your client. It is also important to look at your own emotions and transparency. So if I feel like me and my client are just hitting that gas and we're going really, really fast, and it does become overwhelming to me as well, I may say that. I may say something really transparent to my client and say, do you mind if we hit the brake just for a moment so I can take a deep breath, because I am feeling very protective of you and I need to do a check-in to make sure where you're at and what you're feeling in your body. Because you can have that vulnerability hangover as well. And that is really uncomfortable, because we have to remember that just because and we'll talk about this in the later module too, is just because the session is over for you, it won't be for your client. Your client's still going to sit with it. Your client's still going to be processing and working through it. You may too, but in a different way. And so pacing yourself helps show and mirror and model how to create that safety externally and then also internally, because you're also protecting yourself while working with your client. Now, hitting that gas, let's talk about hitting the gas. Knowing your client really well is really important. Being able to accommodate your client and also recognize certain behaviors, eye contact, baselines. If anything is shifting at all, we need to be attuned to that. But we also need to be attuned to ourselves and how fast we're going. Are we missing pieces? Can we dive in and make it a little bit more detailed? Often, even when working with my supervisees too, I see that they're like, okay, just give me the whole picture, or just give me, tell me about your stressors or your anxieties. And the client goes in and talks about these stressors and anxieties. They're like, okay, we talked about it. Like, now I don't know what to do, where to go. So the therapist starts to feel stuck. There are so many intricate details within an experience, even looking at the way that the client's eyes may shift, or how are you feeling in your body whenever the client starts talking about something? Are you starting to get tired? Because if you're starting to get tired, that's a sign too of like, maybe we need to be more attuned to this. So hitting that gas brake system, pacing yourself, very, very, very important, cultivating this external safety and trust. The next one is respond by honoring behaviors, thoughts, feelings, and protections. I say this over and over and over again. I reiterate this. There is a catharsis to helping a client shift from my responses are shameful, my responses are my fault, I should be past this, the shoulda, coulda, wouldas, to let's honor this space. Let's congratulate you on protecting yourself as well as you have. I wouldn't say it in those words, but it may assist in their language shift too, in that they come in and they're like, so this week was really hard and I struggled a lot with, not self-harming this week, but I really wanted to self-harm, and talking about, well, how has self-harm protected you in the past? And how is it protecting you now? What is it about self-harm that helps protect you and saves you from difficult emotions or difficult physiological responses? Offering grace and compassion consistently. We will talk about in the relationship how being nice or empathic can also be threatening, and it's simultaneous and they work together, they coexist. And so we'll talk about that, but still offering grace and compassion is really important. Know when to assist in replacing protections with practicing new skills. I put this in here because I have also seen a rush in coping skills. let's talk about coping skills. The way you're doing this, we could shift this and that's no longer serving you. So let's replace it. If the person is still in an environment that is uh, traumatic, so to speak, or is not in the right headspace for themselves or emotional space for themselves to want to shift those protections, then we're really just stripping someone of survival. And it's really important to be looking at that and creating that safety. It's okay that you have this. Let's talk about, do you want to keep it? And at what percentage do you want to keep it? Let's say the person is a binge eater. Let's say they're binge eating as a way to protect themselves and to cope with really intense emotional and internalized oppression. I may ask my client, let's look at your binge eating. If that's something you want to look at and you see it as a problem, which often also comes from our social cultural scripting, let's talk about how it's not serving you and how it is serving you. Now, how much do we want to get rid of this at this point? Or do we just want to work around it and like process it more and talk about it, or, slowly start replacing those behaviors and working on it? Because when we look at a behavior that has been very protective and then all of a sudden we're like, we're going to work on stopping it completely, that can be really triggering, and it can automatically set in this feeling of failure for the client. And then it's hard not to want to give up. So, something to think about. The next one is noticing tension, body signals, discomfort, and being attuned to your client. Again, that goes to your baseline. I watch how my clients walk in. What are they wearing? Do they look differently? How are they scanning the room? Are they sitting somewhere different? How are they sitting? Is their body shifting? When is it shifting? Is it something we're talking about? Is it something we're doing? Is it the week they've had? I constantly am watching their bodies and their body signals and signals for discomfort and being attuned to my client. I don't call out every little thing, because that too can make someone feel really nervous or over preoccupied with how they're presenting. Instead, I say everything is invited in this room, bring it all. So I notice that when we talk about this, your body starts doing this. Tell me what your body is saying. Let's go and talk about, is it pulsating? Is it burning? Is it cold? And just helping mirror that attunement with the self and letting your client know that you're also attuned to them. So when they do get flooded or they do get overwhelmed, they feel supported, validated, and like you're capable of assisting them and guiding them to regulation or stability. The next one is offering breaks. Empower your client to tell you when they need a moment, to tell you no, to explore their thoughts and the relationship. With complex post-traumatic stress disorder, and with every client, but especially C-PTSD, that empowerment over the self has been stolen. And it's really important that in our offices, we offer that back to them. You are in charge of the session. I will help guide you. I will be here to support you. I'm going to, validate these experiences. Please know that you can tell me no. If you're not ready, you're not ready. Allow your client to help direct. Now, a lot of clients with C-PTSD have not used their voice in a long time, and so that may be difficult. Checking in with them, I can see that you're in a lot of discomfort. Would you like to continue, or do you want to shift gears? And continuously offering those choices and that empowerment to shift or to move. And if they say no, also being careful not to take it personally. Okay. The next one is provide a sense of control over the collaboration of the sessions and of the self. There's no right or wrong, good or bad. Something my therapist did that I really appreciate, and it was very consistent, and I talk about this in the CBT portion in module 6, is that consistent and persistent language of, I like to say there's no right and wrong in my office. There's only a gray area. Everything is a protection, and what comes up is invited. when we're looking in binaries, like something is good or bad, that's when we're going to start using self-judgment. That self-critic's going to kick in, that self-hatred, self-blame, etc. And so um, whatever you choose in here is a choice. And you can always make it right for you. And that's something that my therapist taught me. And I really enjoy that. And I try to implement that as much as possible with my clients as well. So again, offering choices. And I go into that more in depth with a personal experience of that and how powerful that can be in module 6. The physical office space. Creating and cultivating external safety and trust starts with your office space. I remember when I first started my private practice, my colleague and I, we had our own private practices, but we shared an office space. And you would walk in and there was this big waiting area. And then to the right was a kitchen, and we kept, healthy snacks and water. And then we each had our own office. And as we were in there with the realtor, my colleague would go in the room and I'd be in my room, and we would fake sob and scream and fake throw up and, bang something really loud and try to really see if it's distracting or if you could how much you could hear each other between the walls. The realtor, I'm pretty sure, had some serious thoughts about us at that point. And so we had to kind of explain what we were doing. But that in and of itself is really, really important, is that privacy and being able to say this is safe and confidential. The other thing, of course, we're often taught is make sure that you also have access to the door and your client has access to the door. That's really important. I like to give a tour of my office when a new client comes in. Let me give you, a tour, show them where the bathroom is. If there's any person outside of myself that they may have contact with, I go ahead and explain that. I have them meet that person, tell them a little bit about that person and the process, and then navigate them back to my office. I may also offer exit routes, whether it be stairs or an elevator, explain the safety mechanisms of the office, and just really go through it pretty thoroughly to offer that external sense of safety, and also so that they know how to navigate the office if needed. Another thing is I make sure not to have abstract art on my walls. It is proven that abstract art, though I love it, can increase feelings of aggression or unstable sort of emotions depending on the client. So I tend to have really neutralized kind of earthy art pieces in there. I also have very culturally inclusive matter, such as, safe space signs, or if I have any spiritual or religious texts or spiritual or religious items, I make sure to have a multitude of different ones so that it's not just focused on one. So I want my clients to come in and know that they are safe and be able to access whatever they want. It's hard because we can't always control the external environment. We can't always control the people that they run into, depending on your office building, or who they may see or who they may not see, or what we have in the parking lot. For example, bumper stickers that may make them feel a little bit uneasy before they come in. I have had a client come in before, and there was some political stickers on one of the cars, and they were like, I wasn't sure, if that was your car, and then if it was your car, if I would feel comfortable, working with you. And so we talked about that, and we really discussed the discomfort there, and also that wasn't. But had it been, I would still go into that conversation with my client and talk about, safety and how we can't always control our external environment, but we will in here to make sure that they're safe, confidential, and there's no distraction. So those are just some things to think about. Many see safety as reassurance. There's a need or a needed balance of expressed empathy, assistance with regulation, and empowered, encouraged self-regulation practices. So again, that's that external safety that we're creating for that client, and then that consistency, persistency, and mirroring or modeling. And we'll go into that in depth too. I love this quote, and I wanted to put this on here, and it's by Janina Fisher from her sensory motor psychotherapy Quote, I am hearing you and I believe you. I'm not shocked or horrified. I am here with you and you are safe as you express your emotion. I love that. And I love being transparent about where I'm at as the therapist. There are times where I may bring up my own emotion with the client. And if they're expressing something, I may divulge, I'm feeling really sad right now. Let's do a check-in. What are you feeling? What's going on in your body, etc. And really creating that space of, this is safe here. You can tell me anything. I'll be open and transparent about where I'm at. And it really opens that door for them to be open and transparent where they're at. Okay. So here's a quote that I really liked, and it's by Anonymous. It's trust because you are willing to accept the risk, not because it's safe or certain. Oh, that one's really hard for a client with C-PTSD. Safety and certainty. Certainty can be difficult because typically they live in a space of uncertainty, but safety, constantly looking for safety. So using disarming techniques if the client may feel or present as defensive. Burns gives really great information about this disarming technique. There's a great example in one of Burns's books about how when he started, he was really young, and a client came in and said something about his age. And instead of being defensive and saying, well, here's my credentials, boo, 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 and laid it out as the expert, meeting them where they're at. Yeah, I am really young. You're right. I can see how this could be a really difficult dynamic for you. And working through that and disarming that can be really, really helpful. And so there's different ways to do that. And I encourage you looking into the disarming techniques. So learn any trigger words and stray away from them until safety and trust are established. I would still stray away from them unless your clients unless that may be a goal, is to be desensitized to those words. And trigger words could be anything. They may not even know the trigger words yet because of the complex trauma. And so it may come up later, like, whoa, that's a word that triggered me. Or, oh my gosh, I didn't realize that was going to trigger me. A lot of times clients come in and they don't realize that the therapeutic relationship in and of itself is the biggest trigger. And so that can be something that is addressed, and also helping create that external safety. So be curious and check in with your client while simultaneously modeling their practice of internal check-ins, voicing emotions, voicing wants and needs. An invitation is necessary. So inviting them in the room, all of them, inviting whatever it is they bring. My clients sometimes will say a cuss word and be like, no, it's fine. I am a therapist that allows it all in. So if you are angry, if you have some rage, let's scream, let's scream into a pillow. If you want to stomp, if you want to sit in a ball, if you want to anything, if you want to curse, I'm okay with that. That informs me and that informs my client about themselves. And then we can work through that together. Patience, consistency, predictability, and persistence are key components. We go into that when we talk about the therapeutic relationship. Repair, repair, repair. We'll talk about this with the therapeutic relationship too in the next module, and that is being open to discussing distrust, feeling exposed, fear of exploitation, fear of repercussions for sharing or feeling in session, and vulnerability hangovers. Remember that when session is over for you, it is not over for your client. It may be enlightening and it may feel really good to them when they leave, and 3 days later, they may be feeling like, what did I just do? Can I walk back in that office? This reluctance will occur. This distrust again will occur. And so recreating that over and over and over again, and recreating that trust is so important. And it can be really difficult, because I know for beginning therapists too, that I've worked with, they're like, I thought I had established rapport. I thought these things, and it isn't about you. This is their distrust, and they're learning to trust. And so when we're learning to trust, walking in each week is just as hard as it was during week one. And then you have this internal war that's going on with someone with CPTSD of, I know I'm safe. I've created this relationship with this person, but my body doesn't feel safe and nothing feels safe, and my alarms are still going off. And so it's, again, that alignment doesn't occur, and that can be really, really scary. And so I always encourage my new therapists and therapists working with trauma or C-PTSD, remember that this has to be persistent and consistent. Like, this external trust doesn't just happen overnight. It's gotten them how many years to get here? It takes a long time for that trust to kick in without any reluctance or without any, and that may not be the goal because they're still protecting the self. And so I may then just talk about, wonderful that you're still protecting yourself. And I hope that it gets easier, and hopefully our work together will make this easier. All right, so cultivating internal and personal safety and trust. This is where we're going on the inside of the person. So establishment of agency and discernment. This is, Julie Simons talks about establishment of safety and or discernment and agency. And we go into this a little bit more in another module, but it's really, really, really important. Another one is exploring and developing boundaries versus requests. Again, the boundaries with the self, and knowing the difference between setting a boundary and being willing to, work with that boundary and not self-abandoning is really important in helping cultivate that internal personal safety. And boundaries are really hard. It's hard work and it's scary work, especially with C-PTSD, because if we go back and we explore, let's just say caregivers, and we explore some sort of attachment disruption or the way it may have been in their home, exploring those boundaries that occurred in their home, maybe they weren't met. Maybe they weren't allowed to have boundaries, and that's often what we see. And so creating boundaries and understanding the purpose of them feels unsafe because it was safer to not have them. And so this can be a really long and very intense process, but a very needed one. So exploring the self and repeating client language or terms used. I tend to not use many terms unless my clients use them first. For example, if we're talking about, let's say, someone who's experienced sexual assault, the word survivor or victim. If my client calls himself a victim, I may then say, tell me about being a victim. If they call themselves a survivor, I might say, tell me about being a survivor. Someone with C-PTSD, a majority of the time what I see, and even for myself, those words are like, make you want to vomit. And it's not that the person isn't a survivor. It's not that the person wasn't a victim or isn't a victim. It's just that those words, again, have been stigmatized. And a lot of times the clients want validation, but not necessarily to be coddled. And they want to be understood. And so sometimes when we use certain language like survivor, they're still surviving. And so that's really hard to be a survivor in survival. And then if we use victim, sometimes for our clients, they may feel like they're still being placed in a category or a box, right? And so I allow my clients to use the language first, and then I will repeat their language or terminology. So empowering and exploring preferences, wants, and needs, that can help cultivate that internalized safety and trust. Again, having them recreate that in the office and knowing that you're safe and your responses will be safe if they have a want or a need when they've been taught to not have any at all, and to appease or to go with the flow or to be flexible. Some clients will come in with C-PTSD who have a lot of wants and needs, and that's okay too. Being able to listen to that and validate that and empowering them to explore those with you can really help with that internalized safety and trust and starting to trust themselves again. Assist in empowerment of attunement to emotions, somatic body responses, and self-regulation. Again, those check-ins really assist. It not only assists with that external safety of predictability, but now we're talking about that internal safety of, okay, I know when I start talking about this, I may have this response. I'll go into later as well. Sometimes having your clients write down what it's like in their body, or signs and signals of flashbacks or signs and signals of dissociation. They may not know that coming in. And so as you're seeing it, or as your client's experiencing it, you guys can all continue to explore that and say, maybe we should write this down. I remember whenever I was or whenever I provided a list of like, this is what it looks like when I have a flashback, and this is what it looks like if I'm starting to dissociate, just so you know. Now, we'll go into dissociation later in a different module in depth, but when a client is dissociating, they may already be in a space where it's too difficult to make that connection. It's too difficult to initiate connection with the therapist. And so it's really important that we're watching and helping our clients to start to learn themselves enough to say, oh, when I get this, I know that this is the onset, and I know that this helps me get out of it. Or if they don't want to get out of it, that's something too to explore, right? So check-ins when you notice baseline changes, shutting down, signs of dissociation, and practicing somatic interventions. So we'll talk about body entrapment and how to do some somatic releasing here in a minute. Practicing neuroception, and this neuroception is really important, and it is something that was created and talked about by Janina Fisher. Pat Ogden talks about it. Neuroception and co-regulation can really help with cultivating internalized and personal safety within this self. And again, it's part of that attunement process. And I'll go into all of that in depth too. So another thing is having the client explore and write any triggers or patterns they may have or know that may lead to dissociation. These may be different things. It could be a cold rush. It could be a hot flash. It could be all of a sudden staring off into space, shaking of the leg, freezing and feeling like they can't move. Dissociation and triggers or patterns can come up very differently for each person. And so it is really important to start being attuned to that and having your clients be attuned to that too, because then they feel safer in that. When someone is dissociated, which we'll talk about later, it can feel really unsafe, because especially if they're frozen or if they're in submit, because whatever happens to them in that moment, or that a fear can rush over the person of what is going to happen to me. Like, I am struggling to move right now. And so that can exacerbate the dissociation or the fear and the anxiety. So collaboratively exploring advantages and positives that thoughts, emotions, and behaviors may mean, what they may mean about the client. Going back to meaning is really important. Clients, especially with C-PTSD, create meaning about everything, whether it be someone's facial expressions or about themselves. What does that mean about me? What does that mean for me? So really collaboratively exploring those will help the person internally. Again, creating those choices, encouraging self-compassion shifts, what they want to feel and how they might respond to someone they love. Often we focus on what they are feeling or what a person is feeling, and it is just as important to say, what do you want to feel? And exploring that. How might that be different? Or is it safe to feel something different? And how might they respond to someone that they love? Again, exploring double standards, these distortions of self. It's often I see my clients who are extremely compassionate, loyal, empathic, and grateful for other people. And they would offer compassion. Let's say if a friend were in the midst of a flashback, they may sit with them and offer compassion and help self-soothe or sit and hold space with, but have difficulty doing that for themselves. Or some of the dialogue that they tell themselves of like, I should be over this, or I should know better, or this is just a normal part of the day. You just need to move on and get over it. Would you say that to someone else that you love? And exploring those double standards can really help cultivate that internal and personal safety. Encouraging internal connections with the parts, inner child, internal pieces, or family systems. And I talk about that in depth in later modules. All right, so let's talk a little bit about body entrapment. What is body entrapment? I call it body entrapment for many reasons. The definition of entrapment is literally the state of being caught in. So I say imprisoned or trapped. So often for complex trauma survivors, the body can become its own form of prison. It's its own jail cell. When emotions, physical, psychological, and sometimes spiritual responses to traumatic events are halted and not completed, the body then stores these as those experiences or entraps it. So the body experiences incessant somatic responses such as flashbacks, ongoing pain and suffering that can result in autoimmune disorders or fibromyalgia, chronic pain, fatigue. Though the research is very vague and lacking clear evidence, many also believe in what is called adrenal fatigue. And so this can be caused by the overuse of the kidneys. So after the amygdala sends a distress signal, the hypothalamus then activates the sympathetic nervous system, and it sends signals to the autonomic nervous system that releases the adrenal glands. And so these glands then respond by pumping the hormone epinephrine, or what you may hear as adrenaline, also norepinephrine, dopamine, into the bloodstream. And then cortisol increases and works over time to curb that function. This would be, I mean, it makes it non-essential or harmful in a fight or flight situation, right? And so that's that overworking of the kidneys and that adrenal fatigue that causes continuous fatigue. And so body entrapment is an inclusive term really to encompass the ongoing experiences of somatization, somatic flashbacks, biological and neurological shifting, and long-term impacts of trauma stored and trapped that's throughout the body. And this may hit a client differently. So that body entrapment, they may most likely have it. With C-PTSD, that this is huge, that body entrapment, that entrapment of or somatic responses, and that holding of emotions that haven't been expressed. So some of the ways that this happens is, one of the ways is called muscle armoring. And muscle armoring can, again, long-term cause fatigue, and it also causes, things like not just muscle fatigue, but organ fatigue, really. And that can be really, really exhausting, and then not knowing what's happening to the body. So muscle armoring is really the development of body hypervigilance. It's your body's reaction to what's going on in that intense kind of constriction. This is where the body's continuously constricting or braced for potential trauma or potential threats. It can be anywhere in the body. I hear a lot of my clients say it's in their upper shoulders, their neck, their stomach, their pelvis. Pelvic floor therapy is something that some clients may go through as well for the body entrapment or constriction of the pelvic area. Somebody's been sexually assaulted. There's many things that can happen with muscle armoring, and this leads to pain issues as the muscles are being overworked and not able to rest. Chronic pain and other issues, including that chronic fatigue that we talked about, that fibromyalgia, all of those can be a result of this continuous muscle armoring. So things like massage or guided muscle relaxation and other things can help manage with muscle armoring. I like to watch my clients and watch when they're armoring, when they're not. What does it look like when they're at rest? What does it look like when they're at their most tense, etc. So somatic responses happen in a wide range of ways, and they show up differently for each person. And these may be immediate or may not be experienced until later in life. The onset of somatic responses can begin for the first time or may be re-triggered by things like medical examinations, situations that may feel unrelated to the traumatic events, but are interconnected in some way. And this is those triggers too that we don't necessarily know. Many complex trauma survivors have learned responses of numbing the pain. And so when that pain comes back, like we talked about before, it can be really intense. It can be really foreign to them, and it can be really, really scary. Especially when medical professionals may not be trauma informed. And not only that, they may not have any treatment for it at all. And that can be really discouraging as well. So some of the responses may include, but certainly are not limited to, hypervigilance, nausea, vomiting, digestive or gut issues, pain in body parts, joints, muscles, and with no other obvious causes. And so this can create restlessness, difficulty with memory, trouble focusing, sleep disruption, and insomnia. And as you can see, all of these things are really frustrating. So not only is the person with complex trauma or C-PTSD experiencing major tension and chronic pain and issues focusing at work or flashbacks coming on, but they're also working through all of these things simultaneously. And that can be really overwhelming, frustrating, and defeating in a way. Okay. This won't stay large, it's okay. All right, so then we have, again, a little bit about somatic flashbacks, and I'll go more into detail about the different types of flashbacks. But the body feels the physical sensations of the trauma as if it's reoccurring in the present. So if the person had a learned numbing response, this may be super shocking to the person experiencing this physical sensation, but it will also be recognizable. So just because the person can't really say if they've had this experience before, they're like, I don't know why, but this feels really familiar to me. So they may not be able to articulate that direct experiential connection to the sensation, but they know that the sensation has been there. So the body is essentially remembering this experience. The body memory is amazing. This may cause extreme tension, muscle constriction again, intense heart rates or intense heat, intense cold rushing of the body, shaking, tremors. All of these physical responses may come with somatic flashbacks. And so some of them may be new and some of them may have been experienced before by the client. There are body-focused trauma responses that feel really overwhelming and take over. So post the somatic re-experiencing often comes exhaustion, fatigue, heaviness, slow movement, foggy vision, and sometimes dissociation. So somatic experiences are exhausting. They take a lot of energy. So really being empathic and validating this experience is really important, because clients with C-PTSD are navigating a lot all at once, and it is really tiring. Yeah. So, all right, let's talk a little bit about the gas brake system. I'm sorry. Risks of flooding are high. So sometimes the body floods with sensations that become so overwhelming that it's difficult to regulate or soothe. One can feel imprisoned. This is that entrapment, overheated, frozen, disconnected, foggy, lost, and so many other sensations that are simultaneously moving through the body, or may even remain what feels like to be stuck in specific areas. I have clients that say, you know, it's always in my chest, or it's always in my pelvic region, or it's always in my gut. So assisting the client in slowing the process sometimes, and attuning to the self, and recognizing and building tolerance for these very difficult experiences assist with the decrease of flooding or re-traumatization in the body and the mind. And again, this is still creating that external and internal safety, learning what floods yourself, and how to regulate that, and creating this like pendulation. We'll talk a lot about pendulation and tolerance building as well as part of the therapeutic rapport building stages. But here's a great little diagram of the parasympathetic nervous system and the sympathetic nervous system, and how it may work, and what we may see, or how the client may feel. All right. So some of the ways that experiential somatics may release are, like we talked about, crying, shaking, shivering, allowing the body. And really what we're doing in this process is allowing the body to continue what was halted during a traumatic experience or continued traumas. And so allowing the client and inviting, again, that invitation, inviting that client to do these things is really important. We can do grounding techniques. This could be shuffling your feet on the floor. It could be butterfly tapping or that bilateral stimulation, rubbing of the arms and the face, resourcing. So talking a little bit about resourcing, we'll go into all of this in module 6 as well. And we'll talk about how to create a resource and what that looks like and really cultivating that. Then we have that pendulation or sequencing. So working the client through something where we're getting their distress points or their stressors are really high, and then pendulating them back to kind of self-soothing, and then or guiding them into me assisting in soothing them, and then back up to a distress point. And so this is how we're building tolerance. And that really helps also with that somatic release, because it gets kind of like, and then that release set. So intentional movement. I invite my clients to move however they please. Please just move. If your body says to like get up and move, or your body says to kick and scream, let's do that. Maybe during the experience, Pat Ogden talks about this as well, as maybe they wanted to, hit something. And so you see their arms fly up and things like that. Now, I do have clients also who struggle with that because they're so constricted that they're afraid to do that movement in front of people as well. And so they may want to do these things and they may want to have these intentional movements, but they may not feel as safe doing them, or have a fear of judgment. Breathing techniques are, of course, essential. Learning to breathe, noticing if your client is constricting their breathing or not breathing at all. Breathing is important. And then there's yoga. I like to integrate some trauma focused or trauma informed yoga or anxiety reduction yoga into my therapy. Sometimes it's a goal for our clients to be able to do things in yoga for trauma, people with trauma or sexual assault survivors or victims, or whatever terminology that they choose to use. Hip openers can be really triggering. And so I have had clients that come in and one of their goals is, I really want to be able to do yoga in the fullest. So I want to be able to do happy baby. I want to be able to do frog pose. I want to be able to do these things. And so yoga can be triggering for some, but it's also can be a goal set in helping release. And we know that hip openers also assist in releasing toxins and assist in releasing somatic entrapped emotion. And then there's meditation. And we'll talk about this too when we go through mindfulness, CBT based techniques in module 6. And then we have mindfulness, Tai Chi or Qigong, somatic experiencing, living, goes through that. And we'll talk more about that in module 6 when we talk about somatic experiencing as an integrative method. Holotropic breath work, the Wim Hof method, again, it's like that cold, the ice, the jumping in the water, soul retrieval, and descriptive language, dance, and music. So these all are beneficial and helpful in that experiential somatic release. And we'll go further into that in depth in other modules. I really appreciate you all being here with me on this journey, and I look forward to continuing having conversations with you in the discussion posts and supporting you. And hopefully you got some golden nuggets from there. Take what you like and leave what you don't. So I'll see you in module 4.